Excellent. All right. Well, good morning, everyone. Thanks for joining us on what might be one of the last kind of Indian summer days of the year. Really pretty day. Weather's about to change. Getting a little feedback, so I might ask everyone to mute themselves unless you are talking. And we encourage talking, but if you'll just unmute to do that and then mute, that would be great. Audio is always the trickiest part of these remote meetings. All right, great. So here's our agenda, and we're going to start with our usual introductions. So we'll go through the folks who are on the line, and hopefully we'll be able to identify all of you to ask you to unmute at that point and tell us who you are. And we'll talk about a few announcements, including a couple of new services that we're excited to hear about. So we've got some people who are going to talk to us for a few minutes about those. We'll do our usual brainstorming session, which is your time to really let us know how you're doing, what you're having trouble with, how we might be able to help. We love hearing about new resources. We love hearing about updates to previous cases that you might have shared with us. We like hearing about whether you've been able to incorporate motivational interviewing into your work and also quality improvement. So we look forward to that part of the meeting. And then after that, we're going to talk a little bit about the Transition Summit that happened earlier this month. This was the second annual, and we're pleased that Stephanie Sund can be with us to kind of help remind us what happened at that summit and look ahead to see what is going to be happening in the next year with regard to helping young people transition to adult health care in Utah. We'll have some time for discussion, and we look forward to hearing how you guys are working to incorporate transition processes into your daily lives, your daily work, and then we'll wrap up by 10. So I'll start with introductions. My name is Mindy Tueller, and I manage the medical home portal, which we talk a lot about in this meeting, and I also help facilitate this group. Let's see, I'll take a peek at who's here, and I'll just go down the list as I can see it. So Erin?
Hi, my name's Erin Shoemaker. I am the administrative assistant for the medical home portal, and I also assist Mindy with these meetings as well.
Thanks. Chuck?
Hi, this is Chuck Norland. I'm the general pediatrician at the university and director of the medical home portal.
Jill Connor.
Hi, I'm Jill Connor. I'm the director of business development at Shriners Hospitals for Children.
Katrina? Katrina Jensen, are you able to unmute? Okay, maybe not. I know that Katrina is with Intermountain and is part of the transition effort that's going on, so we're happy that Katrina's here today. Ileana.
Hi, this is Ileana from Southwest Children's Clinic, and I'm the manager here at the pediatric office.
Terrific. Katie.
Hi, everybody. My name is Katie, and I am the care coordinator at the University of Utah Pediatric Clinic.
Terrific. Walt.
Yes, good morning. This is Walt with the Integrated Services Program, and I'm with the State Health Department, and I'm a care coordinator with them.
Terrific. Glad you're here, Walt. Dora.
Good morning. My name is Dora. I am the professional relations coordinator at Shriners Hospitals for Children.
Terrific. Natalie.
Good morning. I'm Natalie Allen, and I'm the nurse practitioner with the Integrated Services Program, Department of Health.
Wonderful. All right, Catherine Hayes. Dr. Hayes.
Hi, I'm Catherine Hayes. This is my brief look at my face. I am the new pediatric gynecologist here at University of Utah Primary Children's Hospital. I see patients in the Eccles outpatient building at Primary Children's, as well as do inpatient consults and surgeries as appropriate. And I'm just super excited to be here in Utah and providing these services, and happy to help your patients in any way that I can.
Fabulous. And we'll be hearing from you in just a little bit. Gabby.
Good morning. My name is Gabi Baragoshi. I'm a quality improvement coach at UPIC. And for today's meeting, I will monitor a chat box. So if somebody cannot unmute themselves, please write in a chat box and I will read out loud. Thank you.
Thank you, Gabby. And Betsy Bagley.
We cannot hear you.
Yep, I just realized that. Sorry. My name is Betsy. I am the nurse coordinator for the new pediatric gynecology. So I'm working with Catherine Hayes and really excited to get the program going.
Terrific. We're happy you're here. Melissa Higley.
Good morning. I'm Melissa Higley. I'm the care manager at Altitude Pediatrics.
And Rebecca, I'm not going to try and say your last name.
Good morning. My name is Rebecca Daniel, and I am a social work LEND trainee from North Dakota. And here we are on, we're in full-on winter, so no Indian summer for us.
Rebecca, we're happy that you're joining us today. We hope you'll find it useful.
Thank you.
Linda Stevenson.
Hi, I'm Linda Stevenson. I'm with Integrated Services. I'm the care coordinator in Central Utah.
Great. Kelsey?
Hi, I'm Kelsey. I am a care coordinator with Integrated Services program down in Blanding at the San Juan Public Health Department.
Excellent. Eric Christensen.
Good morning, Eric Christensen. I'm the program manager with Utah Department of Health Integrated Services program.
Wonderful. Gina Everett. Maybe Gina can't unmute. I think Gina is with Utah Valley Peds. And I see a Heidi. I don't have a last name.
It's Heidi Bates, I'm assuming, unless there's another Heidi. But hi, I'm the I'm the other QI coach with UPIC.
Hi Heidi, glad you're here.
Hi, thanks.
And Tomoko.
Hi, I was able to. I'm able to attend just the part of this, but I'm Tomoko. I am how do I say, adolescent and young adult cancer patient navigator for Huntsman and Intermountain Cancer Care Program.
We're so glad you could join us, even if it's just for a little while.
Thanks.
And Jade Porter.
Hi, yes, sorry, I'm only here for a few minutes again. I have another meeting again, but yes, glad to be here from University of Utah Health Plans.
Good morning, Jade. All right, and Nikki. See, Nikki, I'm not sure if you can unmute. Maybe not. I think Nikki is with Busy Bee Pediatrics.
Yes, Nikki is the nurse up at Busy Bee. Mm-hmm.
That's right. Okay, terrific. Well, that's everyone I can see. And if we have more people join us, that's terrific. But we'll go ahead and move on to some housekeeping and announcements. So we're happy that you found a way to join us this morning. Our best experience for these meetings is typically being able to log on, whether it's on a computer or a mobile device. That seems to be the better experience than just a phone call. So we hope that you'll try that. And we're going to try and end promptly at 10 o'clock and respect your time. So as we mentioned before, we have a couple of new services to talk about, and so we're excited to turn the microphone over to Dr. Hayes and Betsy Bagley to talk a little bit more about the new pediatric and adolescent gyne clinic.
Great, thank you so much. So just a little bit about me and my background. I am a fellowship trained pediatric and adolescent gynecologist. I most recently came from Boston Children's Hospital, which is where I did fellowship. I also was in the military for 8 years. So I did my residency in San Antonio at the military medical center there. And then I served overseas for 3 years in Germany and a year back in San Antonio as faculty. So I was a generalist OBGYN for 4 years before going back to fellowship. And this is a service that I think everyone recognizes was very much needed here in Utah and the surrounding states. We have just been seeing clinic for less than 8 weeks even, and are already very busy and expanding our clinic days. So I can see the full depth and breadth of pediatric and adolescent gynecology. And Mindy, I can send you a slide afterwards that you can distribute to the group that has kind of all my information on it, so that people know when to get how to get a hold of me. If you are in an Intermountain facility, you can place a consult through iCentra for pediatric and adolescent gynecology. If you are in the University of Utah, you can fax us, or you can reach out to me by email, or just whatever way makes it easiest for you to get a hold of us is perfectly fine. And we're happy to see all patients and help in whatever way we can. What else can I tell you about?
So is there an upper limit on age range for patients?
Yeah, so for patients who are otherwise healthy adolescents, I'll see them up till 18. For kids who have other kind of medical problems that make them more complex, I'm keeping them until probably about 21, kind of through their first pap smear. And then we are working with various departments and various OBGYNs to develop some transition programs, because we're a little bit unique in that I know a lot of pediatric subspecialties tend to hold on to their patients for a long time, but OBGYN adult problems become, or GYN things become adult problems. And so we are really trying to be proactive in helping to make a really good transition experience for our patients.
That's great to hear. And as I mentioned to you by email, we're all about transition right now. So that fits so nicely. And we're delighted to hear that you guys are really paying attention to transition for your patients. So excellent.
Definitely.
That's great. Well, Dr. Hayes, one of the things that you may not yet know about this group is that we meet monthly, and that after every meeting, we send out a summary of the meeting, and that always includes any service providers that we've talked about and a way to get in touch with them. So we'll make sure to get that slide from you and make sure you have all of the correct information, and it'll go out to this entire group after the meeting.
Great. Thank you so much.
Thank you so much. We're really excited about knowing that this is available now. Great. All right, and Jill, if you want to talk a little bit about your new fracture care hotline.
Yes, thanks, Mindy. Thanks for the time. So Shriners Hospitals for Children, of course, we are all things orthopedic in nature, and fracture care, we've always treated fractures. However, it's kind of one of our more underutilized service lines. We recently implemented a dedicated fracture care hotline to manage these incoming fracture referrals. The number, and I will also leave some collateral with Mindy to post, is 801-888-4068. That number is available to accept calls as well as text messages. Weekdays, 8:30 to 4 is when that line will be open. It is important to keep in mind that Shriners does not have an ER. So again, we accept stable fractures, but no open wounds or trauma. The nice thing about this fracture line is it is triaged by a skilled nurse who does have ER experience. So she's able to better triage those calls. So we can be that first line if that fracture is suitable for us to treat initially, for us to see those and treat those patients. So, and our care includes anything from triage, splinting, casting, surgery, post-fracture care follow-up, as well as rehabilitation. So please keep us in mind for those fractures. We would love to see more kids come our way, and especially in light of the pandemic, we thought this was a great way to help divert those patients away from, the hospital setting in some cases to avoid COVID exposure. So we definitely are excited about this new line. So thanks for your time. Any questions? All right, and Mindy, I will send some collateral for you to post.
Okay, that's great. And I actually got the email that was specific to the new dedicated line. So yeah, I think the fact that you can text it is terrific. So that's
about that option.
Very good. So again, we will make sure that information about both these new services go out to this group after the meeting, so that you're able to jump on that information very quickly, and we'll make sure it's added to the Medical Home Portal Services directory as well.
Great. And one more thing I just wanted to point out, Mindy, is that families can always self-refer. So in lieu of providers making the call or text, families can also call or text. And we do have collateral available in Spanish as well.
Excellent. Very good. Yep.
Thanks, the same goes for me too. Everyone can self-refer. So you can refer a patient, but patients can also self-refer into my clinic as well.
That's good to know. Thank you. All right. Okay. Wanted to let you know about some updates on the Medical Home Portal. So we've done an update on our page about gastroesophageal reflux disease. And we actually have a brand new diagnosis module on Charcot-Marie-Tooth disease, hereditary motor sensory neuropathy. Say that fast 5 times. So that's some new clinical content and updated clinical content to let you know about. We've also been working hard on our families content. So we have some updates to some frequently asked question pages on 22q deletion syndrome and intellectual disability and global development delay. And then we've made updates to some other pages as well, service support and therapy animals, after high school options, again, kind of transition oriented, estate planning trusts and accounts, and screening tests and the diagnostic process. So hopefully those will be of interest and of use to you. Okay, so we're moving on now to our brainstorming time. And as I mentioned before, this is really the time that you guys get to connect with each other, bring up anything that's been difficult or challenging that we might be able to crowdsource a little bit, any new things that you're doing in your clinic or your organization to deal with COVID. We like to hear all of it. So please feel free to unmute yourself and or put something in the chat, and we'll just use this time to talk about what's going on with all of us.
I would like to give a shout out to Southwest Children's Clinic. They just achieved their patient medical home recognition. And as many of you know, that's a 1-year time of hard work. So congratulations.
That's huge. That's really great. Ileana, we're very impressed.
Thank you very much, and thank you. It was a lot of work, but we had great help.
And so I'll just make sure I understand. I'm assuming that it was UPIC and the quality improvement coaches that helped you guys get back.
Yeah, I couldn't have done it without Gabby. She was excellent, and she helped my lead, and very supportive, and just excellent things just to get us through it. It was interesting, but it's done.
It was a journey.
Yeah, I think it can get pretty intense at some point. Does that sound true?
Yes, yes, it can. And just getting everything together and just making sure that the staff was trained on what we said we were doing, because we were doing it. It's just getting them to say, this is what we're doing. So so it was good. And again, couldn't have done it without Gabby.
No, that's terrific. So patient-centered medical home designation, how does that change things? I mean, you've got maybe some new processes, and you've got trained staff, so certainly, wonderful for patients and their families. But are there any other changes in billing that happen?
So far, not in the billing piece, but I think what's most important is actually knowing how we're doing, because as you run reports, as you see, the panel of patients that you have, and missed opportunities, there's a lot of things that you get to actually look at your practice and actually be able to decide, hey, are we missing out or doing this? Or especially now with COVID, it was great because we were running reports. We knew what we needed to, who we needed to call to get back on the schedules and get back on track and actually keep our business going, which was really important. But I think that if you're not conscious of, what your needs are and where you need to improve, it's a little bit harder, because, they could have maybe 1,500 patients each, and I have like 7 providers now, and it's very difficult if you don't have a system going.
Wow, that's really interesting. So more internally focused. That's great.
Mm-hmm.
Well, congratulations.
Thank you very much.
Okay, anybody else? Talking. All right. Well, let's see. Let me go to the next slide. So quality improvement, clearly what Southwest Clinic has been working on. Does anyone else have anything to mention about quality improvement processes they've been doing?
Can I just put in a little about quality improvement? This is Heidi with UPIC, and just letting you all know we are starting our asthma collaborative again, their initiative, and so there's still time to sign up. If any of your providers need MOC credit, this is a good thing. Or if you're PCMH and this will satisfy all PCMH requirements through quality improvement. So if you're interested, just let me know and get you signed up.
Great, and we can put that your contact information in the summary notes as well, Heidi.
Thanks, Mindy.
Great. All right, does anyone want to just mention how things are going with COVID? Anything that you're doing differently? Anything that's changing now that it's fall and the weather's getting cooler and kids are in school?
Mindy, I guess at Southwest Children's Clinic, I wanted to mention we started, we actually been doing our flu clinic, and it's really interesting because we may find that this is the way we want to do it in the future, kind of like the new norm. It's gone really smooth, and we've done drive up to our back parking lot, and patients do all their sign up and everything the night before, and then they just come through the drive through and get their vaccines. Patients really enjoy it. They like having all their kids in their car and just getting all the vaccines done. So it's really interesting because with this COVID, I think there's a lot of things that we find that that this might be the new norm that works out really well. Doesn't bog down our lobby, doesn't the kids don't interact with sick kids. So it's been nice. And I guess with COVID, there's a lot of things that we've actually learned, and it might be, like I said, the new norm moving forward, but it's been positive. We thought it was going to be quite a challenge, just with what we needed to do and how we were going to do it, and if we were doing it appropriately based on guidelines and insurance, but it's turned out to be really positive for our clinic.
Oh, that's great. It's always so nice to hear when there is a silver lining. And I mean, I think there often are things that we can learn when we have to, change something, when we're forced to change something. So that's really good to hear that this is, you've made changes that are helping and can be applied even if there's not a pandemic. That's great.
Yeah, and I think the patients also feel comfortable just because we were having a little bit, where parents really don't want to come in the clinic. We had our challenges with not everybody wanting to use the mask, but now I think everyone's kind of used to that. And I think to a certain degree, I think it's going to help with the flu season also, because staff is protected in a certain way better than we have in the past years, so I like to see how we do as a clinic with sick calls, even within our own staff, because we do have to mask all the time. So this cross-contamination might be something good and might be moving to the future also.
Yeah, so interesting. And now you're tracking everything, so you can go ahead and make that comparison. That's great.
Yes.
Excellent. Okay. Okay, anybody else? All right, well, hearing none, we'll go ahead and move to the next part of our meeting. I can switch my slide. There we go. All right, so I think you guys are mostly aware, mostly all aware that we had the Transition Summit earlier in October. And I'm hopeful that many of you were able to make that. It was a virtual meeting this year, but it was great. I learned a lot and really enjoyed being a part of that, and listening to the panels that took place, hearing more about the GOT transition elements, and understanding what's going to happen next with this project and this effort. And so we're really grateful that Stephanie, who's really been a huge part of all of it, is able to be here with us today and kind of do a bit of a summarization of that meeting and let you guys know what's going to be happening next. So Stephanie, I see that you're here, and if you want to go ahead and be the voice, I'll just advance the slides as you let me know.
Okay, perfect. Great. Thank you for having me, everyone. Yeah, again, for those of you who don't know me, my name is Stephanie Sund, and I'm an RN, and I do teen to adult healthcare transition for Intermountain Healthcare. I've been doing it for about 3 years now, and just in the past year, 2020, became the lead. 2 years before that, I was helping pilot a transition program called the grad program, and it was part of a study. And now focusing primarily on teen to adult healthcare transition throughout the system. So what you have on your screen here is a photo of myself, obviously, but then also on the left is 9 building blocks. So in 2020, there was a primaries campaign that they were raising money to put money towards 9 building blocks, and teen to adult healthcare transition is one of those 9 building blocks. So there's definitely a lot of backing behind this, I would say. Next slide. Okay, so my job also is I collaborate with Got Transition, the National Alliance for Teen to Adult Healthcare Transition. I'm doing some investigative work throughout the community to investigate their work through transition. What are they doing? What do their workflows look like? How can we start getting transition into clinics? I help helping just networking, building these relationships throughout the community so we can figure out who are pediatric providers, who are adult providers, who are some of these adult providers that are willing to take some of these complex kids. Really just trying to get the word out, and honestly, a lot of it is just boots on the ground, hands, person-to-person communication. What have we heard from this person that you've heard about this person that I mean, and that's what really is so helpful with having you guys as care coordinators and having the UCCN is because we can work together. And I've already worked with a few of you and heard, have had you reach out to me and starting to really figure out this puzzle of transition. So I help lead a few work groups at Primary Children's Hospital, and then I do act as a consultation service. So a few of you may know this, that you can reach out to me if you have complex patients or issues. I can try to help you work through them. I don't know that I'll have the answer, but if I don't have the answer, I'll definitely know who to go to help with that. So. Okay, so some of our transition work groups that we have we have a community-wide transition governance committee that's held at Primary Children's Hospital. Well, virtually now, obviously. But this is just a few examples of people that are represented throughout this governance committee that we have. We also have a few subgroups, the Summit Planning Committee for the Summit, a value-based payment committee, metrics, where we talk about metrics. We have a policy, and then our transition survey that was sent out. So we have a few little subgroups kind of working underneath this big governance committee. And the governance committee has about 30 to 35 people on it. And representing, I couldn't even show, I didn't have all the cool icons to show you, but we have population health. I mean, we have just so many representing transition, which is really, really cool. If you are ever interested in going to that meeting or attending it, let me know and I can send you dates. Next is the policy. So we've started a policy, and this is just an example of it. I'm not going to read it off, but if you want a copy of it, let me know. We just want to make it really generic. If this would be from the pediatric office to the adult, to the family, kind of explaining them what transition is and kind of helping us all get a starting, kind of a place to start. The next thing we talk about, we're looking at is metrics. So just some examples of our metrics. Gosh, this slide is very small. But, the time frame from leaving the pediatric provider to finding an adult provider, availability of adult providers. We're looking at cost data. We're looking at the number of fallback visits and the continuity of prescriptions and DME supplies. Just an example. So if you're ever interested in any of this, more information, just let me know and I can get more information to you if you're curious. We have there's a lot going on behind the scenes that people don't realize. Okay, so there's a survey that we sent out this year. Many of you completed. So we sent it out to 232 individuals, and out of that, 21 of them, 86 filled it out. And out of those 86, 21 of you were UCCN members. So I'm pretty happy about that. That's about 25% of you who filled out the survey were UCCCN members. So I really appreciate you guys taking the time to fill it out, filling it out as best you could. that's really helpful. So, and you can see that we sent it to a lot of different people throughout the community, throughout Intermountain, University of Utah, unaffiliated people. We've really broached, I would say we've broached just about everywhere in the healthcare system. I'll just be honest, except for Mountain Star and is it IASIS? I think you guys probably know better than I do. But there's a couple small companies we haven't broached, and then the big Mountain Star. I don't have anyone that I'm speaking to. I do know of one physician that is interested in transition that works for Mountain Star, so that's like a starting point. But if any of you ever that's where it comes down to us networking and talking together. If any of you hear of people like, oh, transition, Tijo don't have transition, and here's somebody at this clinic or that's willing to lead it or is interested in it, or there's somebody at Mountain Star who, will you please just send me an email, because the word of mouth, like I said, is really getting to be the best thing, because I'm only one person, and so I am just trying to figure out who's out there and really trying to get us all together, working together. So anyway, there's my spill on that. Okay, back to the survey. Sorry. So we sent it out to, you can see which different roles there are. 35% were MDs or DOs, 28% were program support, 16% care managers, 8% nurses, 6% nurse practitioners, parent. We did this year send it out to some parents, more parents this year than before. And I have gotten some feedback that it wasn't very parent friendly, and we realized that we were just barely touching the surface with the parents on that. So we actually want to have to send out a parent survey come in 2021. But all we've done is really talk about that we want to do it. And so that's something that we're going to work on later in the year. And then you can see 50% were pediatric, 14% adult, 10% med peds. And then we've got integrative services, the local health department, and family support. Okay, so some of the age-specific results. So these questions, what we asked was specific to transition, transfer, and at what age is, what age is their opinion that they should be transferring. So, okay, so yeah, by what age on average do you aim to transfer? So they aim, it looks like, gosh, this slide's so small. It looks like 53%, but I'm half blind. I would know, you would think I know these slides, but I don't. I don't have them memorized. Okay, so yeah, 53%, and it was the same 2019 versus 2020 that they all aim for 18. So they all have in their head that 18 is the cutoff. And then there's a few stragglers that are a little later in age. So that's when they aim. When do they actually transfer? So you can see the spread of when they actually transfer is way after 18, which is understandable. A lot of us realize why this is happening, but also we want to do some more investigation and see how we can bring the needle back a little bit closer to 18, 19 years old. But obviously, I know I'm preaching to the choir that every patient is different, and there's complex situations and patients, and not good adult providers to take them, and all that stuff. So that's our challenge, is kind of bringing that needle back over, but we'll figure it out, I think. And if not, we'll just ensure that they get good transition support, because sometimes they are not even getting that. So, okay, next slide. Okay, so at what age do you think transition planning should begin? So this actually slide makes us who have been working on this project really happy, because we're really starting to push transition age at an earlier age. From what you guys may remember, we're really starting to push at age 12. So you can see on this slide, 12 to 14 years, it's gone up quite a bit since 2019, and then gone down at that older age. So that is great, and that's what we want to see. So we'll continue that progress. Okay, so some barriers to transition. These slides are a little bit small and hard to see, even for myself. But they're talking about lack of available adult PCPs, So you can see that the blue are major barriers. So a major barrier would be, obviously, we all realize, lack of adult PCPs to care for us, lack of adult PCPs who are comfortable taking those patients. The next one would be lack of available specialists, patient and family pediatricians who have developed an effective bond. So you can see that that's not as much of a major barrier, but somewhat barrier. So that's definitely, it's important for us to realize what our barriers are, how we can start overcoming and breaking down some of these barriers, and then to realize that, you know, the bond obviously is very important, but it's not something that's not workable or that we can work through. So, next slide. Let's see, talks about the lack of knowledge that adolescents have. That's pretty high on the somewhat barrier. That's also a barrier that we can easily break down, especially if we start doing transition education and starting it earlier. I don't think we would see that barrier as much. Pediatric and staff lack sufficient time. So that's obviously always a challenge. That's more of a somewhat of a barrier than a major barrier. But that is, the time issue is, you know, we only have so much control over the time, but that's why when I'm meeting with clinics, I'm really looking at what their workflow is, what does their staff look like, how many FTEs do they have, really trying to focus on who do we think can lead or help be like a stakeholder in transition, or someone who's really passionate and can help lead, who can do the work, who actually is available. Is it a care coordinator like yourself? Is it a social worker? Is part of it the provider? Is it a care manager? You know, what does that look like? And every clinic's going to look a little different, obviously. We also, it looks like, is talking about lack of knowledge about community resources. Looks like that's kind of a somewhat of a barrier. And then another major barrier would be fragmentation of primary and specialty services in adult care. So that's something that we're working through with these kids who have so many doctors and so many specialists. And even if they only have one specialist and one PCP, it's still, you know, you probably see it, but I see it that a lot of them just don't get a PCP, and they just think they can go to their specialist for everything until they're like, oh, wait, I got strep throat. Now what am I supposed to do? So we really try to encourage that they keep that PCP up once they become an adult. It seems to get forgotten. Okay, next slide. Okay, so we asked about what, does your practice or center have a dedicated transition clinic or program? We had 18 responses that were yes, and the ones listed here are ones that I know have, that I'm familiar with all of them except for Copperview. I have not talked with Copperview Medical Center yet to learn about their services, but Primary Children's obviously has a few quite ones that are going really well. And then Integrated Services does a lot of transition work. The Scenic View Academy has a really good transition program for autistic patients. And then you guys have probably heard about Transition University with Utah Family Voices that Jody Hanson created. So that's really great too. So there's a lot of them up and coming. There's a lot of them that are just getting started, just not, you know, and then there's some who haven't done anything. So we have all sides of the spectrum, but that's what I'm here for, is to help really start implementing transition in these clinics and really figuring out how we can do this and just keep pushing this little train forward. It's kind of my analogy, is because it is this very slow moving train, but it's definitely moving forward. So it's pretty exciting. Okay, so we talked about the 6 core elements. And for those of you who aren't probably familiar with Got Transition, is a national alliance that we're benchmarking some of our model off of, and that's these 6 core elements. So we asked in the survey, we asked people what level they were on. So the 6 core elements are to evaluate them at level 1 through level 4, basically. I'll just tell you briefly what the results showed. So looks like the policy, so having a policy like I had showed earlier, that is definitely increasing. It's gone up from a level 1 to level 2, so that's better than nothing. Tracking and monitoring, we used to not have very little, and that's gone up quite a bit, a whole level. I will say that some of the clinics are doing really well, and so some of these clinics are like at a level 4 already in each of these, or maybe just one of them they're a little short, but so this is just a general overview. I can look up in the survey and find out what clinic said they're at what level, but just, this is everybody. So readiness, basically assessing their self-care skills, offering the education, ensuring that they're ready to transition and transfer to adult care. That has stayed the same, except for the people that were in level 3 are now in level 4. They're doing really well with readiness. We have a readiness assessment that's out that we're starting to use. That's a transition readiness assessment. And it's just becoming, those who are doing transition are really realizing how important it is to evaluate their patients beforehand. So planning, obviously there's a lot that comes into that, but just developing their medical summary, their healthcare transition plan, making sure they know about emergency care. There's a few things that go along with planning. And then the planning stage takes years, but so we really want to start, you can see that these things we consider them to take years in time. That's why we really want them started so young. The planning level has gone up from level 1 to level 2 and in the majority, but we also have some that have gone up to level 4, which is great. And then transfer of care, that's gone up a little bit. People are getting really good about following. People who have programs are really good about following up with the patients, making sure they do transfer, making sure they are linked in, they like who they are seeing, they have a good communication with the adult provider, a good system set up to transfer medical records, that kind of thing. And then going on to the transfer completion, they try to get the patient feedback, maybe adult care or anybody's feedback, really to elicit feedback to find out how this went, how can we improve, and what went well for the patient or the family. So that's the 6 elements and what each of them kind of mean. They've created a 7th element and an 8th element, and those were not evaluated on the survey, but I will just briefly tell you that they don't, if you were to go up to Got Transition's website and pull up the 6 core elements, it'll still say 6 core elements, it'll still have 1 through 6. 7 and 8 are embedded within 1 through 6, and so that's why you don't see them as separate elements if you're confused. I wasn't sure about that, so I had to ask the main lady in charge of transition. But okay, so the 7th one is youth and parent feedback. We're realizing just how crucial that is to be able to get feedback from both of them, really to help improve our processes and to involve them more in supporting them. The 8th element is leadership, so youth and parent leadership. So how often are they helping us create some of these documents, review them, just give them out? How often are we having them look at our policies, our websites we're creating, the website, the readiness assessment, just anything like that we're giving out? How can we help them become leaders in creating these kind of things and using them and making sure they're really focused around the family and the patient? So that is what those 2 elements are. All right, let's see. Next slide. Okay, so let's see. So also in the summit, we did an exercise called the patient journey map, and I'll just briefly tell, well, it's not brief, but I'm going to go through kind of what it is and briefly show you one. If you want to see one in more detail, because it is quite detailed, let me know and I will email you one. But basically, a patient journey map is a tool that's used in customer care. And in this case, the customer is the patient and the family. It's found useful in healthcare settings, especially with quality improvement. It follows the patient through their lifespan, or in this case, the ones we've created are through their teen to adult transition years. It illustrates all the people, things the patient and family is in contact with through their journey, and describes their skills and the patient's, their transition skills and their growth over time. The patient journey map is very powerful in that it illustrates how patients and families navigate such a challenging healthcare system, all the tasks that they have to be familiar with, be able to do, medical care, all the lifestyle changes that come up, personal relationships, dealing with their emotional well-being, and then their transition needs. Like I said, it follows them through every stage of their care. And as we look through the journey map, what we had people do is we had a list of questions. We would break out into breakout groups, and we had a list of questions. But before we even started, I wanted them to just encourage to think about where they might fit in the patient's journey, and at what points might they have the most impact with this patient. So yeah, the patient journey map really focuses on these 4 things. So needs, feelings, and attitudes, the experiences of the patient's journey, and then the on-stage people and things. So the things and people that the patient comes in contact with daily, make a really big difference in the patient's lives. You know, just people that the patient has to deal with on a regular basis. And things the patient has to do. When I show you, it'll make sense. And then backstage would be people, and then things. I've added things that are related to transition kind of as a backstage, so we can keep the journey map kind of focused on transition. So some things to consider. These journey maps are from a perspective of primary children's patients, looking back over time, so real patients. They're showing their high points and their low points of their experience. So you'll see under their emotions and needs that there's quite a lot going on in their lives on top of their health. Let's see. And then just consider how a tool like this could be useful in continuous improvement, and determine where there were opportunities for improvement in their transition process. So let me show you what a journey map looks like really quick. It's very busy. Okay, so you're like, what are you talking about? I can't even see it. So that's what I mean is if you want to get a copy of it, I'm happy to email you one. But basically the top is her needs and feelings. And can you just scroll in a little bit, Mindy? Okay, let's see if it's not super clear. But from okay, so this is Elise. So Elise's big thing, she's a type 1 diabetic who got diagnosed when she was 12. She went to 2 separate Instacares before she was sent directly to the PICU and DKA, and in the diabetic ketoacidosis, like the diabetic coma. And then her and all of her family received all her education inside the ICU at the hospital. So her journey first started out that she went to 2 Instacares. They didn't know what was wrong with her, and then she finally was so sick that she got sent to the ICU. So her needs and feelings at the beginning was a lot of fear, unknown, insecurities about the providers. Do they even know what's wrong with her? That kind of stuff. And then you can see the experience goes down. She's diagnosed. She's in the Instacare. She's in her PICU. She gets her education. She has to go to diabetes clinics every 3 to 6 months. She starts junior high. Then we go down to on-stage people, which would be her parents, the Instacare staff, the hospital team, bedside nurse, the phlebotomist. So why did I put the phlebotomist as on-stage people? Because when they're in there, unless the nurse is drawing the labs, the phlebotomist is there all the time. So they get close to the phlebotomist. Like, that's someone that they're having to deal with a lot. On-stage things would be all their, pumps and IV supplies in their rooms and stuff. The backstage people, Mindy, if you just scroll down into the green, the backstage people are people like health insurer, medical clerk, medical records, the answering service, the pharmacist, people like that. And then I have at the very bottom, backstage things related to healthcare transition. And so each of those just goes through the timeline of what she should be doing at that time in her life to learn about transition. So learn to care for herself and her diabetes, learns how to self-advocate and how to talk about her diabetes. And so you can see this map follows her through her ages. So it starts at age 12 when she's diagnosed and goes all the way to how old she is now, which I believe is 22. And so we follow her experience through her high school, graduating high school, starting college, starting nursing school, moving out, in addition to all of her healthcare stuff. And then on top of that are her needs and her experiences, or her feelings, in the very top yellow. And Elisa's journey, we made 2 journey maps, and Elisa's journey looked a little bit different than the other girls, but Elisa's journey, her big thing was that she really had a hard time admitting that she had diabetes. She had a really hard time wanting to do anything at school, so she would hide it. She'd go into the bathroom to do it. She didn't want anybody to know. So that affected her quite a bit for a couple of years, actually. And so her experience and all of the kind of everything that flows back down this chart kind of goes along with how she may have had to overcome some things. And then if you're in her life at that time and you're starting to talk to her about these things and you realize that she's doing these things, then how most can you help impact her and empower her to not be afraid and not say she's hiding them. And you may not even know that she's hiding her diabetes. She might lie straight to your face about it. But that was her journey, and she eventually, came to terms with it and learned how best, with the help of her diabetes educators that she saw every 3 to 6 months, and her diabetes team really helped kind of empower her and show her kind of the best ways to go about doing something like this if you're not so sure about it. So that was kind of her journey. The other patient's journey map we did was a patient who had received a heart transplant, and her journey looked very just different in the fact that it took her years and years and years to get back to where she was pre-heart transplant. She just became so deconditioned that she had a hard time getting back into school. She had to be kind of kept into a little bubble because she was immunocompromised. And then she couldn't even physically get through a day of school because she was so deconditioned. So that's kind of what a patient journey map is, if that makes sense. It just follows them through their life or their whatever years you want to follow them, and really paints a picture of all the things that the patient has to go through and experience, and just how impactful your presence in this patient's life can be at all these different touch points. So if you guys have questions about the journey map or want information about it, let me know. And again, just email me. My name is just stephanie.dawson@ino.org is my email. Okay, so lastly, the last thing we did in the summit was we had some panels. So I wanted to show the pictures of the people that were on the panels, just to show like these were real people. And it was a really great experience listening to all these people talk. So our first panels were adult providers. So we had Dr. Lim, who's an adult hematologist, Dr. Jones, who works at the Uni Home, and I believe that's a home for autism. Correct me if I'm wrong, someone. And then Dr. Bank works at the intensive outpatient clinic, which is a clinic which takes complex patients and helps, kind of acts as like a med peds almost, so they can be seen by both sides and they don't actually have to transfer out of that clinic. They can stay within it. So the IOC is a pretty new clinic. Okay, but some of our takeaways from our panels. Okay, so just the big thing with communication, a phone call with a former PCP plus open communication for the first year, a summary document with emphasis on social issues, a care conference or a telehealth visit with a pediatric adult with their counterparts. If you can include the patient, that's even better. Ownership of care. The provider can empower the patient to educate the teen along the way. They're their best educator and advocate, other than the parent, I would say. Parent involvement at the right level, and understanding, I would say understanding where that parent's involvement is huge, and understanding why that parent might be like that, and not just trying to change the parent. And just kind of meeting the parent and the patient where they are. Trust from the pediatric provider transfers trust to the patient, their family. Of course, be open, be flexible and adaptable. Don't see the patient as their disease. And make sure you know that this all takes time, communication, FaceTime, building the relationships, making an upfront effort to meet the other clinicians in your system in your area. So that's kind of the stuff that the adult provider panel talked about that would be helpful for them as adult providers. The second panel we had was a parent panel. And these are the parents. And so Shauna Sherman, who's the parent of Julia, that's Julia there with her. Heidi Bricky, who's the parent of Mia Bella. Mia Bella was funny. She said they didn't have any recent pictures of them together. I was trying to get a picture of the parent with their child. And yeah, no, she said not for like years. I'm like, well, you and your mom need to take a picture together. Come on now. But yeah, it's Heidi and then Tammy Springer, and that's her son, Tyler. So Shauna is a parent of a type 1 diabetic, Heidi's a parent of a heart transplant patient, and Tammy's the parent of a Tyler has cyclic vomiting syndrome. So that's kind of their history and kind of what they've experienced a little bit. So their takeaways was the hardest challenge in the transition process was having enough time. Adult care is very fast-paced, and then finding that right adult medical person. Trying to do transition long distance without knowing anyone, not having an advocate. So Julia Sherman, her daughter, moved to California on a scholarship. And so Shauna was having to find an adult provider in California for her. So that's what that's talking about. Provider can help empower parents to take the time to educate their teen about their health care. That it's just really huge to be able to have the parent, like it, my big soapbox is that the parents really know the patient in and out, and they know their healthcare in and out. And so really empowering the parent to take the time to educate their child or teen about how to fill prescriptions, about how to call, about, you know, all the X, Y, and Z tasks that they need to learn along the way. And the provider can be huge about empowering the parents on that. Let's see, looks like Tammy said best help from the peds care team would be collaboration with Cache Valley Hospital, reaching out to Primary Children's Hospital in Riverton and following their care plan and communicating with the patient and family. And that's huge, following someone's care plan, especially when it's a complicated care plan. And this family has spent years and years trying to figure out a care plan that's best for him, that helps him best. And so to not change those things was huge. Heidi talked about having a designated care coordinator within the peds clinic that helped transition to the adult clinic and gave that kind of warm handoff, attended the first child's appointment with them, and how helpful that was. And then their wish list. They talked about identifying an adult healthcare companion for the youth at least a year in advance. Or if I said companion, I meant to say champion, sorry. A healthcare champion, at least a year in advance, meet with them ahead of time. Needing that provider support and transition education beginning earlier in the teen years. So yeah, having that transition education is huge, but then also, you know, the whole identifying an adult healthcare companion, or oh my gosh, champion for the youth, that could be, in my opinion, yes, I think having an adult healthcare champion is important, but I think just having a champion in general, just someone who can be on both sides. So having someone that can really support them through this transition stuff is going to be huge and is going to make a really big difference. And so that's really what we're hoping to accomplish down the road, which I'll talk a little bit more about our 2021 goals. But so yeah, the parent panel was really empowering. They all had really powerful things to say, and yeah, I thought it was great. So the teen panel we had last, and of course this was my favorite because I love my teens. So there's Miss Julia, she's a type 1 diabetic, Mia Bella, she's heart transplant, and then Isaac Wolf has hemophilia. And so they all three spoke just so well. They all were just really eloquent. I'm the one who led it, and I didn't do anything to help them practice. I just said, these are the questions, be prepared. And they did so good. And they're all like older, so they're all in their early 20s, so they're not 14 or anything, you know, but I was just so happy and impressed with how well they spoke. So what they said, what the pediatric could do to help them was, so meet the patient where they are at their lives. Really, and that goes for the adult team too. Julia expressed concern that she is an athlete and she's a type 1 diabetic, and diabetes and athletics go hand in hand with dietary food, right? Knowing about what you're putting in your body and how much insulin you need and how much energy you're expending. And she had a regimen down that was working for her and a great A1C, and she went and saw this new adult provider, and he wanted to change it all up. And he didn't want to kind of respect her wishes about what she wanted to do with her training. And so really meeting them where they are in their lives and doing the most that you can to respect their values and wishes goes a long way. Let's see, start talking about transition early, going into details, talking about those kind of things they're going to need to know. Allow for time without the parenting visits. Even if it just has to be just a gradual, you know, just mom, you know, step outside for 2 minutes. And even preface it as this is just a way of practicing. A lot of patients just have their parents talking for them for the first 18 years of life. And by the time they get to that adult side, they're like, what am I supposed to say? What questions am I supposed to ask? So really just starting with the baby step of just have dad or mom step out for 2 minutes, and we're just going to practice, like you being in here with just me, think of a question you can ask me, just little baby steps, and then they'll become confident. So that was big for them. Let's see, work on knowing obviously who their adult counterparts are. They really think that the pediatric team could really, and we all, I feel like, could agree with that. Let's see, get the relationship with the adult provider in place earlier. Yes, we've heard that. That's kind of been an ongoing message. And introduce the patient to the adult provider before the real visit. Yeah, and we realize that that's, you know, some of these things that are on their kind of wish list is just so clinic specific. on what they can do. I know of clinics at Primary Children's who can definitely do that, but I know clinics out in the community or that's just not possible, right? So, and that's totally okay. It's just us figuring out how we best can figure this out and work around what barriers we do have. So, okay, they lastly said what the adult team can do to help meet the patient where they're at in their lives. Like I said, don't make big changes in the first plan and the first part of the year. Tammy had expressed this as well with her son Tyler, that they moved adult doctors, and then their adult doctors wanted to change up all these things, and now he's not doing as well as he was before they transferred. So just not making those changes in the first year, really kind of trying to learn your patient and figure out what's working for them best before you make a lot of changes. And then obviously working on knowing who their counterparts are, so on the pediatric side. Okay, where are we at here? Where we go? Okay, so during the parent panel, a parent, Jody Hansen, many of you probably know her, with Utah Parent Center, she created this map based on her son's journey. So this is not a journey map, patient journey map, but it is like a map that's showing his support systems and his journey throughout his support systems. So it's hard to see what's on here, but let me just tell you real quick. So he's at the center with his family. Then he's got, in the orange, he's got all of his different supports. So he's got his church support, he's got his aid, he's got transportation, he's got his special education, his therapist, his special education teacher, looks like some community members, his brother, and then on the other side is stuff about his health, his legal, his finance, his people. So you can see just how many supports he has. School supports, he's got tons, all on that left. Health, legal, people, he has tons of supports there. And he's even got some legal support, some senators, some political support, all sorts of stuff. So then you can see as he gets older and he transfers to adult care, how many supports start leaving, and he doesn't have those anymore. So just watch how things just gradually start disappearing. And next thing you know, he's got very few supports. He's graduated school, so he doesn't have any of those school supports. He's not starting school. And then he does start developing some new ones that are on the adult side, mostly health related. So he does get some supports back, but you can just see just how many he's lost. So this is just an example his mom wanted to create to just show just how people really don't realize all the supports that are lost once you transfer to an adult provider. And I think that adult providers do have the supports. It's not, saying anything bad about adult providers at all. It's just this was her experience, and it's hard, if he doesn't go to school, if he doesn't start school again, then he's not going to have all those school supports because he doesn't really need them, I guess. But anyways, a lot of us thought this was a really powerful image. So, okay. So lastly, I just wanted to talk about what our 2021 goals and plans are for the year.
Sorry.
You're good.
I changed the slideshow and now it's.
Oh yeah, so you could see the.
Yeah. I'm not sure what's happening.
No worries. Does anyone have any questions at all so far? You can speak up or put them in the chat.
My name's Heidi. I'm one of the UPIC coaches. My son is special needs, and I just wanted to, I know you said that he didn't have any school support because he didn't need it anymore. I don't think that's necessarily true. It's like once you graduate, those school supports are gone, but one of the issues is that they still need it. It's just not available because they're older.
Yes, that's true. Yeah, yes, this is true. I misspoke. So yes, he definitely would still need it. He's just not, he doesn't have it available because he's not using their resources anymore. So yes, I apologize for that. Thank you. Okay, so the 2021, our focus areas, I'll still be doing a lot of networking and meeting people in clinics. And so we really want to start working with the staff who are interested and willing to help with transition in their area. We're going to start, we have 2 toolkits that we'll be really starting to use. One is already created, it just needs to be maybe slimmed down a little bit, but it's based off of the GOT Transitions toolkit. So there's a provider toolkit and a family toolkit. The provider toolkit is a generic toolkit, can be used for primary care or specialty care and pediatric or adult. And then the family transition toolkit, Noel Taxon and Eric Christensen with the Children with Special Healthcare Needs Department of Health are leading creating the family transition toolkit. So I'll be working with them throughout this to create that. And we'll be working on integrating the readiness assessments into the medical records. So we already have it integrated into iCentra. It's just not live yet, like people can't use it and we haven't trained people on it yet, but it's pretty much done. And then we're just trying to find out who in Epic is our go-to. So we are kind of just in the limbo of that. I'm trying to get it into Epic. We will be offering webinars in the first quarter to educate staff on specific tools like the readiness assessment, like a portable medical summary, different things like that that can be used in transition and transition education, and figure out kind of what are those first couple tools you can start using to really start the transition process with these patients, figure out how to start kind of tracking that throughout clinics. And then obviously our goal would be to actually integrate these tools into the clinic's workflows. So that being said, we are really trying to figure out who in which clinics are going to be the best people to really represent transition and be able to do the work. So like I've mentioned, is it a care coordinator? Is it a care manager? Is it a provider? Is it the social worker? Is it a combination of people? Some of the clinics that we've seen do really well. It is a combination of people and they are working as a team and they each have little parts to do. And they all keep track of it. It's tracked in one central location and they all know how to get to it, and it's very, so we've seen a lot of ways that people have been successful and how we can help other clinics be successful as well. And so just know that I may be reaching out to some of you this year and into the fall to really see if I need to contact people within clinics, and you guys as care coordinators are really the place to start, because you can help me link with yourselves who do a lot of the work. A lot of you are probably already doing a lot of transition work. You may just not realize it. A lot of the stuff isn't super complicated. And then also helping me connect with those in your clinic that would be able to do transition if it's not you, or just being able to start that conversation with your managers and your staff and figure out what that looks like within your clinic. I haven't really gone into community clinics very much yet, so only we have a couple that are willing to start piloting some of these tools, which is great. So just so you know, you'll be hearing from me, and care coordination comes up a lot in conversations as support staff that may be able to do some of this transition work, which is really exciting because we know, many of us know how important the care coordinators are to clinics, how it's like almost like you're the glue that you're like the glue that keeps things running and keeps things together. And so I really appreciate having so many of you interested and so many of you in these clinics that will be able to start this giving more transition support. So it's really exciting. So yeah, if you don't have any other questions, that's all I've got. But yeah, feel free to call my work cell, text my work cell, or email me with any questions. And again, please, if you find of anybody who is interested in transition or can help, no matter who they work for, please let me know so I can help collaborate with them. That would be great.
Stephanie, this is Pat from Select Health. Can you
Hi,
hear me?
Pat.
Hi.
Yeah.
The reason why I logged in late to this meeting is because I was on the meeting about the pilot program from the pediatric congenital heart to the adult genital heart. It was very hopeful. It was a great discussion, and I think to start with a small clinic, a specialty clinic like that, is a great way to start and to learn things. And the discussion included how to get the PCP involved in the transition, and at what point do they transition, and all of the things that have been discussed. They actually have on paper, and are really working towards that transition plan. And I was quite impressed with the integration of all those tools.
Oh, good. That makes me very happy. Yeah, I'd heard that there was some stuff going on in congenital heart.
Yeah.
They just hired a new nurse practitioner, is it?
I think they've got a couple.
Yeah, and we do have Ian Lindsay and Matt Anderson on our governance committee, and we do work pretty closely with them. So
Yeah,
that is great, and I'll just follow up with them and see if I can be of any help.
Yeah, it was Ian that did a lot of the presenting information, but it really, it came down to, the fees and, how to bill for care management, and it presented a really promising picture of the transition to specialty clinics, let alone just, a kid who's turning 18 who needs to move to adult care. So it was very good.
Good. That's great. Thank you for sharing that. I appreciate that.
Excellent. Well, thank you so much, Stephanie. And does anybody else have anything they'd like to ask Stephanie or mention regarding transition? I think this was really helpful. And, as I mentioned at the top of the meeting, I really enjoyed the summit, and I would encourage all of you who, next year, who are able to participate in that again, and certainly to fill out the survey. It's really helpful information to track progress. But also, it sounds like there'll be some opportunities for webinars coming up that'll help make you more familiar with these tools and really what's going on. Stephanie is a wonderful, very responsive resource, so you can see her contact information here, and of course we'll send that out as well. So again, Stephanie, thank you so much for taking this time to bring us up to speed on how things are going with regard to transitioning young people to adult health care. I will say that the adult healthcare panel at the summit, they were kind of like the ideal adult healthcare providers and probably not the norm. They were amazing. So if your patients have the opportunity to utilize their services in any way, that would be ideal. But the other thing about the two, the Uni Home Clinic and the inpatient, the IOC, the Dr. Bank is part of, they're both Medicaid. So that's a little limiting. And of course, that's kind of the landscape these days, right? It's not always available to everyone to have these great services, unfortunately. So All right. Well, thank you so much, Stephanie, and we'll make sure that these
thank you.
These things go out in our meeting summary. So excellent. All right.
Great.
See if I can go to our next slide. There we go. So, oops. I can get back to that. So our meeting next month is on November 18th. And we're still working on what exactly that's going to look like. So more to come on that soon. I want to apologize about those Jacob Care Map slides. They didn't work out for me in the presenter mode like I expected. I'll try and make those available to you. It was really dramatic in the summit to watch the animations occur on those, and what we could see as the animations changed is that it was, pretty dramatic how some of the services and supports in Jacob's life changed as he became an adult age-wise. And I think you'd appreciate seeing that the way I had seen it. So I'll try and get those sent out if you'd like to take a look at them. Pretty interesting. All right. Well, I think we're at the end of our meeting, so I want to thank everybody who was able to join us today, and to those who presented and participated. So we'll just wish you a very safe, healthy month in between now and our next meeting, and we'll see you in November.
Thank you.
Bye, everyone.
Thanks, Mindy. Bye.